This is Soundcheck, your go-to podcast for ultrasound quality assurance, image review, and clinical education from MedStar emergency physicians. We walk through real cases, highlight what to look for, and dig into how ultrasound guides decision-making. Here's your host, Dr. Jon Watson.
Hey everyone, and welcome back to this episode of Soundcheck. Today is November 1st, which means that Halloween's officially behind us. I hope everybody had a great one. We've got a solid lineup of cases this month, including one that fits the spooky season perfectly, having a ghost twin, along with several other really interesting cases from across the MedStar system. As always, I'm joined today by one of our resident co-hosts to bring some new voices to the show and share fresh takes on these ultrasounds. In this episode, we'll be reviewing ultrasound cases from across MedStar Health system, offering teaching pearls, pointing out what to look for on your next scan, and talking about how we can all improve the quality of our ultrasound work through this QA process. And make sure that you stick around to the end of the episode because I'll be chatting with Dr. Joelle Bohart, Program Director of the Emergency Medicine Residency Program at MedStar Georgetown and Washington Hospital Center, about an article that she co-authored in the Annals of Emergency Medicine on optimal positioning for transvaginal ultrasounds. It's going to be a great episode, so without any further delay, let's go ahead and get started and bring in our co-host, Dr. TJ Zlupko. All right, so today I'm joined by TJ Zlupko, who's one of our resident physicians. We're going to go through some cases together. TJ, thanks for being here today.
Happy to be here. Thanks for having me.
Of course. Yeah, you ready to get into these cases?
Let's do it.
So this is a middle-aged man who came to the hospital, had a history of chronic pancreatitis, and had a history of a pseudocyst. At one point, he underwent a hepaticojejunostomy and came in with epigastric and right upper quadrant pain.
Okay.
So it looks like they're doing a fast exam here. So this looks like it's the right upper quadrant. Right upper quadrant view. See anything abnormal here?
Taking a look at the liver, looking at the kidney here. This looks to be normal.
Yeah.
Normal Morrison pouch.
Yeah, so we're kind of looking for free fluid, any kind of incidental findings in that area. We see the liver and kidney, a little bit of the diaphragm curving around here. But looks okay so far. Do a little bit more of the right upper quadrant. Have a little rib shadowing here as well, getting in the way, but overall don't see anything abnormal. And then they're including the liver tip down here as well, and just make sure that there's no free fluid there. And then we get to some kind of more interesting findings. We have another view here. This is the subxiphoid view of the FAST.
Okay.
So we see the heart squeezing. Looks like the function's okay here.
All right.
Anything abnormal you see about the liver? This is sort of like the left edge of the liver that's just anterior to the heart right there.
Yeah, so within the liver space there, it seems to be these three bright white lines here, some hyperechogenicity. Mm-hmm. That's not normal.
Yeah, I agreed. Yeah, so you see these hyperechoic densities here within the liver. So that actually is the appearance of air on ultrasound, but air within the liver is abnormal. So this is actually the ultrasound findings of pneumobilia. So why, though, do you think, based on the patient's history, he may have air?
So I guess for this individual with his history of surgery and the connection between the liver and the jejunum, there could be air, within the bowel that is backflowing or backing up into the liver, and to be expected, I guess, in this individual.
Yeah, exactly. So with the hepaticojejunostomy, there's some surgical connection made between the biliary tree and the jejunum because there's some sort of obstruction elsewhere within the biliary system, so it needs to drain that way. So that air that's normal bowel gas within the jejunum can reflux, kind of retrograde up into the biliary tree. So that's sort of an expected post-operative finding in someone with a surgical history. You'd be more concerned if this is a new finding or it's more diffuse, or the patient presents with concerning findings like fever, right upper quadrant pain, and sepsis type vital signs. All right, so this next case we have is a middle-aged man who came in, presented with shortness of breath and had a lot of abdominal distension. So the clinicians were evaluating for anasarca and ascites, and actually ended up doing a fast exam to look for any signs of a big fluid pocket that they could tap with a paracentesis.
Okay.
So we're looking here at right upper quadrant. What do you notice? Anything about this right upper quadrant?
Looking at the liver, we're looking for kidney below it there. Nothing really standing out too much on this one.
Let's take some more views here. One thing that they just didn't label, so just make sure you all label your views so we know what you're looking at. They got it on this one though. Now we're seeing the little bit better view of the right kidney here on top of the psoas muscle. You can see a little bit coming into view in and out right here. Looking around the liver, anything of note?
Yeah, so we have some rib shadowing there, down like the central part of the liver. As we look towards the top right of the liver at the point there, apex of the liver, we see some fluid, like a small fluid collection there. Guess that could be any number of things: blood, bile, ascites.
Yeah, urine potentially. There's no history of trauma in this patient, but with the abdominal distension that they were considering ascites. So let's take some more looks here. Now we're going to go through the left upper quadrant, and we're trying to get views of the spleen and the left kidney.
Okay.
So walk us through kind of what you're seeing here.
Yeah, so that the spleen is that organ on the top left. Below it, you are to the bottom right, you're looking for a kidney that doesn't necessarily look like the normal structure of a kidney. Right there, that circular mass type structure does not look like normal kidney structure, more so of like a mass.
Yeah. So this is definitely looks different than a normal kind of renal cyst, right?
Mm-hmm.
So renal cysts are usually anechoic and small, usually benign ones less than 5 centimeters. But you have this heterogeneous kind of solid mass-like structure in the area where the kidney usually is.
Okay.
And then you have some central clearing here, which maybe a small amount of fluid within it internally. So what do you think this may be?
If it's like a solid mass on the kidney, less likely to be some sort of cyst, and worrisome for a potential carcinoma or cancerous growth.
Yeah, exactly. So it was measured later on CT. It was 11.5 centimeters and was found to be growing off of the kidney. So concerning for malignancy, and got further workup that diagnosed renal cell carcinoma.
Okay.
We also see some other findings in the left upper quadrant. We see here the diaphragm, and then you see a little bit of fluid above that as well, so like towards the patient's head. So this is some pleural effusion as well, kind of wrapping around above the diaphragm. We see it a little bit better in this view as well. The teaching point for this case is just when you're doing any type of ultrasound exam, just be on the lookout for any incidental findings, because they will definitely change the patient's management.
Okay.
Okay, next case, we have a woman who came in her early 30s. She is pregnant, a G1P0, says she's about 13 weeks gestation. She came in with vaginal bleeding and had a clear fluid leakage. What's going on here in this ultrasound?
So in this ultrasound right here, we're looking at the M mode of the uterus, and normally we use the M mode to help calculate fetal heart rate. There's a calculation essentially based on the distance between the heart rate flashes on the M mode, and then this can help calculate the BPM for the baby. And you want to, there's a normal fetal heart rate range, and if we're looking in the right or the left-hand corner, upper left-hand corner, we see it's 190, which is too fast for a fetus at this age.
Yeah, this is pretty elevated, so it'd be classified as fetal tachycardia. And you're right, you're using M mode, kind of look with the M mode cursor over the fetus's heart, and looking for a repeating pattern somewhere within that depth range, and that's how you calculate the fetal heart rate. So we'll go through now live scan of the transverse uterus. So we're looking at the uterus here, the globular structure, and then what do you notice about the fetus here?
Yeah, the top left-hand corner, we see the head or the cranium there, and then as it extends down towards the right, you see the spine of the fetus. One of the things that we're looking for is the amniotic sac And in this individual, it looks like we're not seeing that large black surrounding sac that we would expect, which is concerning
Yep.
for this fetus.
So if you were speaking with the obstetrician, how would you describe the amniotic sac findings here?
Well, we would say that it's non-existent, or two words to use would be oligohydramnios or anhydramnios, and that there is little to no amniotic fluid in this individual.
Yeah, exactly. So let's take another look at the longitudinal view. We're seeing kind of the same, where the baby's in there, but it really has no fluid surrounding it. So this is unfortunately a grave condition for the baby, and it's unfortunately not survivable in an early gestational age, just because the baby's now exposed to external elements. Technically can increase the risks for the mother to get infection, sepsis, hemorrhage, and unfortunately it's a non-survivable condition for the fetus. It's measuring at 13 weeks and 3 days here.
Okay.
When you're looking through for the fluid, there's really not much to measure here, but have you heard of any other ways that you can measure fluid?
There's a pocket depth gauge that you can do for fluid status, essentially within the amniotic sac. The MVP?
Yeah. Maximum vertical pocket.
Okay.
But can you use that in first trimester?
I believe that's a second and third trimester tool.
Yeah.
So here it really wouldn't apply.
Right. Yeah. There's nothing to measure here, but also it's not validated in first trimester. It's really only after 16 weeks or so when you can start using the MVP measurement to look for and rate oligohydramnios and polyhydramnios and things like that.
Okay.
What's the diagnosis here?
So for this case, this would be preterm premature rupture of membranes, or PPROM.
Exactly. All right, for this next case, we have another young woman who's pregnant, who came in with vaginal bleeding. So the sonographer did a bedside ultrasound. So here we're looking at a longitudinal view of the uterus here. So see anything notable?
Yeah, we see right off the bat that there's a baby within the uterus. We see the head, which shows up as like a bright kind of oval shape there, and then extending down, you see the spine kind of curving around, and the baby is in fetal position. But interestingly, it looks like directly behind this image, there is almost like a twin in sync with this baby. But, as we have been reviewing this image, it's seeming more like an artifact of the first image rather than a twin. If you see the fetuses, they're in sync and they're actually moving at the same rate. They're doing the same exact motions, like they'll touch their nose right there and then come back. And so unless these are twins that are synced up perfectly,
people say twins think alike and are in sync, but this is identical movements here. So what you're describing is what we call mirroring artifact, or sometimes people describe this as a ghost baby, where this is the uterus here, outlined by the cursor, and this is the true actual intrauterine pregnancy here. And then you have this mirroring artifact that's causing the appearance of another baby just to the side of it on our screen. So if you notice and you compare the two, usually the true fetus is brighter, right? It looks a little bit crisper, whereas the ghost fetus here, it looks a little bit more hazy and not quite as bright. So this is an ultrasound artifact that can occur when you have an ultrasound beam that reflects off a highly reflective interface. Like sometimes it's described as the bladder or the bowel or the psoas muscle. Can cause this phantom or twin or a ghost uterus, sometimes people call it. But really the key is looking through and looking for the fetal movement and that differentiation and the kind of the intensity of the image that's portrayed.
Okay.
So if we look through, now they do a transverse view, and that artifact largely disappears, right? We're scanning through now in transverse view, so the probe is pointing towards the patient's right, and they're scanning head to toe, and you see one baby within the uterus here.
Okay.
Usually if there was twins, you'd see one and then you'd see another one there too.
Okay.
So this confirms that this is just a singleton IUP with a phantom twin there to the side. You see a little bit of the mirroring artifact in this view here. Just at the beginning, you see a little bit of the head, but it doesn't really continue. So if you do get this artifact, you can just change the angle of your probe, and just them changing from longitudinal to transverse mostly eliminated this artifact, but it was really kind of cool thing to see.
So the double check is really important before announcing you have twins.
Yes, for sure. So they're measuring fetal heart rate again, which we went through before, using M mode cursor. Got a fetal heart rate of 150, which is normal for this age range. And then now they're measuring for the fetal dating. So they are measuring what's called the biparietal diameter here, and it's measured at 14 weeks and 6 days. Why don't you think that they use the crown rump length in this situation? Because we did see a pretty good crown rump length earlier.
Yeah, so the biparietal diameter is an effective date at measurement, oftentimes because you're able to get that distance between the two sides of the cranium. Sometimes with the crown rump length, the positional changes of the fetus can affect the measurement. Sometimes they're extended, sometimes they're more curled up in a ball. And so this is a more standardized way, for lack of a better term, in order to date the pregnancy compared to the crown rump length.
Yeah, exactly. As the pregnancy develops, you said it's going to get longer, and then the baby could be flexed at the neck, and it's going to throw off your measurements. So usually after around the second trimester, we switch to other techniques like the biparietal diameter. Okay, next case, we have a healthy woman in her 30s who the day before her ER presentation went to get acupuncture done on the left side of her back, and she came in with chest pain and shortness of breath. So what sort of scan are we doing here, and how do you get this image? What's the technique?
Yeah, so we'll normally take the ultrasound probe. You can use the curvilinear, or you can use the vascular linear probe.
So using the linear in this case, you can tell by the footprint up at the top, but either one will work.
And you're looking for, the main thing we do when we do a fast exam and we look at the lungs is for lung sliding, which is essentially you want to make sure that the lung is sliding along the chest wall, and there's a certain artifact that we find, a certain image per se. That bright white stripe that's down about halfway across the screen there is normally where we'd expect to see lung sliding. And normally we look for something commonly called ants on a log, or this shimmering effect of those 2 points meeting in the lung and sliding creates this movement or shimmery effect along that line that we're looking for.
Yeah, good. So yeah, the parietal and the visceral pleura should be attached to each other, and when that happens, with respirations, you should have that shimmery kind of lung sliding appearance of the pleural line here. So this is the pleural line, this hyperechoic line here, and as we're looking at it, you don't really see that ants on a log pattern or anything, right? So it kind of looks more or less static. So what are some other ways that we can evaluate the movement on ultrasound?
So then, to go off this, we would normally put the ultrasound in M mode and take a look at the movement over time between those structures.
Yep, so this M mode, like you said, is movement over time. X-axis here is time, and then movement along this line that we're setting. So about halfway down here, we have where our pleural line is, and then usually we have a change in the M mode pattern kind of when we hit that pleural line. How would you describe this finding here, though?
So this is concerning because this is something we call a barcode sign, where we're not noticing a large difference between that delineation line. Normally we expect to see something like a beach sign or
seashore
effect, and we notice a difference between movement happening within the lung sliding and the more static chest wall. But here we're getting this barcode sign because there's static activity globally between the two structures over time.
Yeah, exactly. So this is really kind of showing no movement throughout, and typically you get that seashore sign Where right here, then you get the kind of the stippled kind of beach appearance down below, but you have these repeating horizontal lines kind of all throughout. That's called the barcode sign or stratosphere sign, sometimes people call it. Here's another example of that. You can see the bright pleural line here and really not a significant change in the movement pattern. So what would you be concerned about? What diagnosis?
For this patient, especially given the mechanism of potential injury, a pneumothorax.
So one other thing that we can find in a pneumothorax is this finding here, where we're looking at the pleural line. Now here it's a little bit more superficial than the previous image, but we can see part of the pleural line here between the rib space, and then we see the pleural line as it continues this way. We see actually a little bit of movement on the right-hand side.
Yeah.
So we have some lung sliding and some not lung sliding on the same pleural space.
Mm-hmm.
So this is called the lung point. And this is the area basically where the pneumothorax has separated from the chest wall, and those two layers of the parietal and the visceral pleura have separated, and there's air between them.
Okay.
So this is pathognomonic for a pneumothorax here.
Okay.
And then to show a good example of appropriate lung sliding, this is a different rib space where the lung is still adhered to the chest wall because this was not a complete, 100% pneumothorax. This is an example of normal good lung sliding through here with the breath. All right, TJ, thanks for going through those cases with me. You have any takeaways that you want to share with everybody?
Yeah, well, I appreciate you taking the time to go through those. Essentially, we have some takeaways from each of the different cases. In the first case, we had a case of pneumobilia after hepaticojejunostomy. And this is an expected finding, actually, the pneumobilia. And we just don't want to mistake it for portal venous gas in a patient with this history of recent surgery. In the second case, we found that fast exams can reveal life-changing incidental findings. And so, like we found, there was that renal mass. And so we must always scan systematically to make sure we're not missing something like that. The third case, we took a look at a patient with PPROM. And the takeaway here is that before 16 weeks, PPROM always leads to a poor prognosis. In the fourth case, we found this mirror artifact that looked like twins. But the important takeaway is to recognize synchronous opposite movements and test with probe repositioning to make sure that it's not truly twins, but it's just an artifact. And then lastly, in the fifth case, we were looking at a case of pneumothorax. And so the takeaway is that the lung point is 100% specific for a pneumothorax, and finding it often seals the diagnosis.
Great. Yeah, thanks, TJ. I appreciate you being here.
Yeah, thanks so much for having me.
So I hope you all enjoyed those cases. Great job to TJ, and thanks again for joining me. We're going to get into a listener question here. We have a question from one of our residents, Dr. Carey. Let's take a listen.
Hey, Dr. Watson. The other day I was in the emergency department at Hospital Center and I was doing a transvaginal ultrasound, but I was having a difficult time positioning my patient. Our beds don't have stirrups and I felt it was difficult to get a good view with her positioning. If you have any tips, that'd be great.
That is a great question, Rachel, and an issue that comes up all the time. I thought the perfect person to bring in to answer this would be Dr. Joelle Bohart, who's our emergency medicine residency program director and is an expert of all things OBGYN related in the emergency department. So she actually published a novel solution to this exact problem in a piece that came out in May 2022 of the Annals of Emergency Medicine as a letter to the editor. I'll put a link to the article in the video description. Joelle, thanks for joining us. Can you give us some background on what inspired you to write this letter?
Sure. In the ED, we're often performing pelvic exams and transvaginal ultrasounds, but most of our stretchers aren't designed with stirrups. That makes it hard to get the right angle, especially because the bed under the patient blocks the speculum handle or the ultrasound probe from fully rotating. Sometimes people improvise by placing an overturned bedpan under the patient's hips, but that's uncomfortable and usually doesn't solve the problem.
Yeah, right. I think we've all been in that position. It just feels really awkward and you're trying to get the probe in the right place and just feel like the equipment's working against you. So what's the solution that you came up with?
It's actually very simple. We realized that a chair with armrest could function as a kind of improvised stirrup setup. Here's how it works. Place a chair with armrests at the end of the stretcher facing the patient's head. Ask the patient to move to the end of the stretcher so their hips and buttock are right at the edge. I usually have them scooch all the way down, tell them it's going to feel like they're about to fall off the bed, but they won't. Then have the patient place their feet on top of the armrest of the chair, just like they would in stirrups. And from there, the clinician can either sit in a stool next to the chair for the transvaginal ultrasound, or they can stand or even sit in the chair to perform a pelvic exam.
I love it. That is such a clever and low-cost practical fix. And honestly, it's probably way more comfortable for the patient than a bedpan.
Exactly. Comfort and positioning both improve. It's not high tech, but it makes a huge difference in the quality of the exam and the experience for the patient.
Well, that wraps up the November 2025 episode of Soundcheck. So remember, if you want to submit a question to be answered on the podcast, you can record your audio question at speakpipe.com/soundcheck. A big thank you to my co-host for this month, Dr. TJ Zlupko, and to our special guest contributor, Dr. Joelle Bohart. For more resources and a full list of all the episodes, visit mepsano.com or check us out on YouTube at youtube.com/MedStar Emergency Physicians. We'll be back next month with more great cases. So until then, go out and put these pearls into practice.